Thanks for everyone for joining. I know we're going to set up a few late stragglers here, and welcome to everyone online. It's my distinct honor and privilege to welcome Dr. Peter Minneci to Grand Rounds here at Phoenix Children's today. I've known Pete for about 10 years, and he is now the Surgeon-in-Chief and Chair of Surgery at Nemours in Wilmington, Delaware. He began his medical career and essentially trained at all of the best places that you could think of. Went to undergrad at Columbia. He did medical school at NYU with Greg Martin, so I guess that's one strike against Pete. His residency was at Mass General, and his fellowship was at some little place called CHOP. He then went on to practice nationwide for 12, 13 years. Rose through the ranks there, became the director of surgical research, the director of minimally invasive surgery, and the director of intestinal rehab. He was then recruited to become the chair of surgery and has eventually rose the chair and surgeon-in-chief at Nemours Children's. Beyond being an amazing academic and then really administrator, he's a profound researcher. He has over about 300 peer-reviewed publications, over 180 to 200 abstracts, many different scientific awards. He has over $10 million worth of funding from NIH, PCORI, and then other things that we were just chatting about. The next study that he's submitting today on non-op management for appendicitis. So you can blame him for all of that we're doing here. But no, the research that he's done has been transformative in terms of what we've done as pediatric surgeons in terms of appendicitis, in terms of ovarian preservation, even anorectal malformations and things like that. So he's been a great, in terms of pediatric surgery researchers and clinical researchers, he's been really significant in the field of pediatric surgery. That, and he's been a great friend and mentor. You can see just the way he leads, and he pushes people to be their best, but does so in a way that really builds them up and does so with grace. And he's been a great friend for me and a great mentor for me over the last 10 or 12 years that I've known him. So it's my distinct privilege to welcome Dr. Pete Minneci here to Phoenix Children's. So thanks, Pete.
Morning. Privileged to be here. I don't know that I can live up to that introduction, but I will do what I can. So we're going to eventually talk about non-operative management of uncomplicated appendicitis. No disclosures, the objectives, because we had to pick some, right? We're going to understand sort of the treatment options for pediatric appendicitis, including surgery, non-operative management with antibiotics alone. Review the risks, benefits, and outcomes comparing non-operative management to surgery, in particular for uncomplicated appendicitis, and then hopefully understand the importance of shared decision-making overall, but in particular when you're talking about uncomplicated appendicitis. So just about every pediatric surgeon at some point does research on appendicitis, right? It's the most common indication for emergent abdominal surgery. Lifetime risk is about 8%. There's a lot of it, and particularly it sounds like there's a whole lot of it around here in Phoenix, but about 70,000 kids undergo an appendectomy a year. It has a significant cost to the healthcare system. It always comes with a period of disability, and we'll kind of get into that a little bit, but there's always some period when people are out of activity, and obviously if you're talking about adults, they tend to miss a fair amount of work. It's a heterogeneous disease, so you can kind of see from the pictures that the upper picture is simple appendicitis and the lower picture is the perforated or complicated appendicitis. And the treatment course really depends on severity. So the first thing I want to do is dispel a couple of myths out there in the world, right? So is it an emergency? So if you talk to lay people, they think appendicitis is a true surgical emergency. I got to get my appendix out or my kid's going to die, or I'm going to die if it's them, right? That, at least in our world in kids, has been dispelled for years within the pediatric surgical community. So in a non-toxic, so a person who's not coming in with a low blood pressure, who's septic and things like that, at children's hospitals at least, if you come in overnight, we give you IV antibiotics and we operate on you the next day. So, and that's become common practice in many adult hospitals now too. So it is truly an urgent, not an emergent operation. And there are many studies out there that predate my career that show no increased risk of perforation by waiting to the morning. About a little more than a decade ago now, a study came out in adults, and I don't know if this was acute care surgeons trying to argue to be able to use the operating resources overnight, but basically saying that if you waited to the morning, you didn't have higher risk of perforation, but you increased SSI, which for any surgeons in the room, it's one of our quality metrics. So if you're hurting, and it could hurt patients, right? So the question is, do we need to operate on appendicitis overnight? So we went back to the drawing board. This is one of the earliest studies I did at Nationwide. We did a multi-institutional pediatric study. We wanted to answer this question quickly, right? No time for a randomized trial, because otherwise we have to change our practice back because it's potential harm. So we used the National Surgical Quality Improvement Program pediatric data set, which is a voluntary data set that you can belong to. And the benefit of that data set is it's prospectively collected sampling data using standardized definitions and standardized data collection techniques. So if you're collecting data here in Phoenix and I'm doing it in Columbus or Nemours, if we belong to NSQIP, we have a trained person collecting it the same way. So we really should be comparing apples to apples. And then we got 6 institutions together. We all agreed to pull our appendicitis patients and then do a chart review to get the times, right? So the times from when they were triaged and the times from hospital admission to when they had their appendectomy. And we looked at whether the rates of SSI changed overall, and then based on complicated or uncomplicated, simple appendicitis. And you'll see a few of these figures. X-axis is time, Y-axis is SSI rate, and whether you look at the total simple appendicitis or complicated appendicitis from the time they showed up in your ED to the time they had their appendectomy, no difference in SSI rates for at least 16 hours. And if you said, well, time from admission, like when the surgical team's actually involved now, does it make a difference? And for at least a 12-hour delay, and actually put one up to 24, no difference over time. So to answer that question, it's not an emergency. So I've changed it. It's urgent. Keep that in mind. It's important that we're all talking about the same thing, especially when we want to think about offering non-operative management for uncomplicated appendicitis. So the other place where people, and this now includes medical doctors, surgeons, and the lay people, right, is that it is a very heterogeneous disease, and your treatment course really depends on what you show up with and how severe we think it is based on the workup. So if you look at appendicitis as a whole, pediatric surgical world has at least tried to move to use 2 terms: uncomplicated, which a lot of people call simple, but should be called uncomplicated, and complicated, which includes perforated, big abscesses, things like that. These are the traditional terms that have been used in different places to go into different pieces, and credit to the Kansas City group. They really came up with these 4 criteria to split the groups into uncomplicated and complicated appendicitis. In general, most children's hospitals see about 2/3 uncomplicated and about 1/3 of complicated appendicitis. When you see studies of non-operative management of appendicitis, the first thing you should do is figure out, are they talking about complicated appendicitis, all appendicitis, or uncomplicated appendicitis? And there's been several papers that have come out in the last couple of years that are pooling them all together and suggest different rates of success for different pieces. So it is important to understand the difference. So let's just kind of zone in on complicated appendicitis for a minute. Here, I think the literature is relatively clear. And you have 2 choices. You get someone who you think has perforated appendicitis. See, I use the term too, complicated appendicitis. And you have to decide whether you're going to operate on them early, or are you going to treat them with antibiotics plus or minus a drain and do an interval appendectomy. And we are fortunate, at least in kids, that we have 2 randomized trials that have looked at this, right? So one done by Marty Blakely and his group, and then one done by the Kansas City group led by Sean St. Peter. And the first study clearly concluded that early appendectomy was significantly better. And the second study concluded that there was no difference between the 2, and you should do what you basically are most comfortable doing. And the difference was the patient population. So if you really look into it, in the first study, they were talking about early perforated or early complicated appendicitis without a well-formed abscess. And the second study, the inclusion criteria actually included patients with a well-formed abscess. Luckily, those 2 groups got together and they pooled their data, and it really became pretty clear. This is a typical forest plot you might see with the odds ratio on the x-axis and then each of the variables. And whether or not you had an abscess changed the outcome. So in the patients without an abscess, there were less adverse events, less unplanned readmissions. In the patients with an abscess, it crosses the no difference line. So my take on all the literature is, if you're talking about complicated appendicitis, if they have an abscess, early appendectomy is indicated. If they don't have an abscess, early appendectomy is absolutely indicated. If they do have an abscess, then there's no difference, and it really falls into departmental practice, divisional practice, what you guys think. I personally prefer to delay because I don't like operating with a big abscess in the field, and I've been doing this long enough that I've had to take a couple of colons out, and so I personally prefer to delay. So now let's get into uncomplicated appendicitis. And the question that really came up was, do we actually need to operate, right? Can you treat it non-operatively? And so this stems from fellowship. So you've got fellows, residents in the room, you go, you see the patients, you admit them overnight because we're not operating on them. And then the next morning you go around and the kid feels better and the parents ask you, they feel better, can't they just eat and go home? Do they really need an operation? And up until I finished fellowship, at least, the answer was always yes, because if we don't take their appendix out, they're going to die, right? Or it's going to come back for sure. So why even consider it? And I took out all the data on sort of appendectomy. Appendectomy is definitely a great operation. It cures appendicitis, and for the most part, everything goes smoothly. But even in modern day, there are definitely complication rates. And I'll have you keep an eye on those numbers, because when I present this to surgeons, the first thing they say is our complication rates are never that high. Our negative appendectomy rates, never that high. You'll see. But one of the lessons about clinical research is when you actually look to measure something, you will find it. If you're not looking for it, it's easy to just subjectively let it pass you by and not pull it into your sphere of awareness. But when you look across the studies, the reported rates of minor complications are about 5 to 10%, serious complications, depending how you define it, 1 to 5%, and a negative appendectomy rate, roughly 5 to 7%. There's always a period of pain and disability. The myth that your kids go back to everything the next day, that is not a true statement. The adults definitely don't go back the next day. It costs a lot of money, so if we don't need to do it, we should consider not doing it. We can actually do it now. So we now, in the last several decades, have antibiotics that are just as bioavailable orally or as IV. So you could basically send someone home with an antibiotic, and they don't have to stay in the hospital for the antibiotics they need for their infection. And we have really good diagnostic abilities with the availability of imaging at almost every center. And at least when we did our multi-center trial and we decided to include imaging as an inclusion criteria, over 99% of the kids being treated at a children's hospital have an imaging study before they go to the operator. So the general idea of clinically diagnosing appendicitis and going to the operating room without an imaging study, although that sounds like impressive, it's not really what happens in practice. And then the whole equation around appendicitis is based on the traditional teaching it has no function. And there is a slow but substantial body of evidence actually starting to suggest that the appendix may actually have functions. And these are just a couple of examples of things that it potentially may do. And these are based on population studies done in international health systems that have universal payer systems, so they can follow patients at the population over time. We can never do this type of study with US data, at least not yet, because we don't have a medical record, a universal medical record number yet. So, but it can be a safe house for commensal bacteria. So after you've had an infection, been treated with a course of antibiotics, it helps repopulate with the healthy bacteria. It's a source of stem cells for tissue damage after a GI infection or injury. And it definitely has a role in the immune function, with associative studies showing that people who have their appendix out have higher rates of cardiac events and higher rates of certain cancers. So then what does the data look like? So I would argue that it's pretty clear that non-operative management of antibiotics alone is a safe and effective treatment option. And you can start with historical data. So submariners, people who didn't have access to surgery, have been treated since the 1950s with antibiotics and haven't died. There is a large body of prospective studies in both kids and adults that are consistent. And that's what I'm going to show you over the next 15 to 20 minutes. And really suggest that it is a safe and effective treatment argument. I would actually argue that, at least in the world of pediatric surgery, there is probably more data to support this than almost anything else we do in practice, because the body of literature is now so strong. So what does it mean, safe and effective, right? So we had to define these as we think about evaluating two treatment options. So in terms of safe, when you think about any surgery, complications is a metric you should be watching. So if it's going to be safe, it shouldn't increase the rate of complications. And in particular to appendicitis, if you want to say it's safe, you want to make sure that it doesn't allow disease to get worse, right? So we don't want to see higher rates of complicated appendicitis. So those were the two metrics we kind of looked in and we'll focus on. So starting with what I'm going to call the historical decade of data. So studies that came out around before 2015 or so, right? There are individual studies that every individual study up until that time showed similar or lower rates of complications. And there was meta-analysis in adult studies that basically showed that overall, when you looked at the populations, the rate of postoperative complications are actually less in the population treated with antibiotics first. There's a fair amount of data in kids. So there were, again, individual studies have all shown similar or lower rates of complications. There were 2 meta-analyses published back in 2017. So if you think about it, that's probably studies that were done 10 years before that. So this body of evidence has been growing for at least the last 20 years, showing consistent results, no difference in postoperative complications or total complications. When you talk about complicated appendicitis, again, all the individual studies and the pediatric studies showed similar or lower rates of complicated appendicitis. The adult meta-analyses also showed that it was probably significantly lower population compared to population. What does effective mean? This is where it gets dicey. And this is where you're going to get differences of opinions amongst surgeons, adults, pediatric surgeons, about what effective means. So when you think about non-operative management, it is a medical therapy for a potentially surgical disease. No different than diverticulitis, tubo-ovarian abscess, things that have gone through this transition before. And you're comparing that to a surgical therapy. So what is the outcome that you compare between the groups? Because if you're comparing appendectomy, then everybody in the surgery group had an appendectomy. So did they all fail therapy? Right? So it's a medical therapy with surgery reserved for non-improvement, right? Or failure of the antibiotics. So there's 2 outcomes that we tend to focus in on when we want to talk about effectiveness. So one is the success rate, because this is what parents care about. What's the chance that my kid's going to eventually need an appendectomy? So that's the one that parents care about. That's the one I tend to harp in on the most. And then from a comparative outcome, what can you compare between the groups? Well, if you compare the surgical treatment strategy with the non-operative treatment strategy, disability days. So how long does it take for you to get back to normal activity? And you can do that for the child, you can do that for the caregiver. And so those are the 2 outcomes that tend to be reported in some format across most of the studies. So again, looking at sort of the data from the first decade, this is a summary table looking at success rates from at initial admission, 30 days and 1 year, pooled across the adult and the pediatric studies. And I would have you look at how consistent those results are, right? So the success rate around 1 year is going to be somewhere near 70%, whether you're an adult or a kid. It's pretty consistent. Most of the studies, if they reported those metrics, they show lower disability, similar or lower cost. And these types of results have been shown in additional prospective pediatric cohort studies following these initial sort of trials. So the biggest criticisms coming into the new decade, which would be about the last 10 years, is that it's predominantly non-US data, and most are single institution studies, and a lot are just cohort studies without comparison groups. So we set out and did sort of the initial clinical trial here in the United States, right? And our hypothesis was that non-operative management with antibiotics alone was going to be feasible and safe in children with uncomplicated appendicitis. And we did a patient choice study, which people have criticized us for over and over again. However, most of our studies were PCORI funded, so we have parents and stakeholders and caregivers as our stakeholders. When you survey a room, and I asked this question, I won't ask this group, but I asked this question the first time I ever brought this study up by show of hands, right? How many people would let their treatment be decided by randomization? When you're talking about for you, about half the hands in the room went up. And then I switched it and said, okay, what about for your kid? Every hand in the room went down, right? Nobody wants to let their kid's treatment be decided by a flip of a coin. So especially on something that's not really out there in the public as a reasonable treatment option. So we did a patient choice study, so families could choose what treatment they wanted, which is also pragmatic in that that's how we do surgery every day in practice. We talk to our families, we come to a joint treatment choice, and then we move forward. This is common practice for everyday surgeons. We enrolled 102 patients, about 37 of them, so about 35% chose antibiotics, and about 2/3 or 65 chose surgery. Our primary outcome was success rate, again defined as not undergoing appendectomy, and we basically showed 94% success at hospital discharge, 76% at 1 year. And then the secondary outcomes, quality of life, disability days, and lower costs all favored non-operative management. So we had what we thought was a successful single institution prospective comparative trial. So then the next question you need to ask is, does it really work? Are the results reproducible at other sites? So then that's an effectiveness question, right? So now we're not looking at safety and efficacy. We really want to know, is it effective? Thinking about some of the metrics we talked about earlier. So we were able to get PCORI funding, and we did a 10-institution trial across the Midwest Pediatric Surgery Consortium. Again, a patient choice trial. These are the inclusion criteria, and these are the inclusion criteria when people talk about non-operative management of uncomplicated appendicitis. These are pretty much the ones that are now being used in just about everybody's protocol. The age limit here was 7 to 18. That has actually dropped, and we chose 7. That was based on consensus. You have to be able to communicate your symptoms, right? You have to say you're feeling better, you're not feeling better. And so when we started this, the surgeons involved did not want to go below 7. Since then, other studies have gone as low as 5, because a lot of 5-year-olds have good communication skills and can tell you it hurts more, it hurts less. So you'll see in our newest studies that it's 5 to 17 years. Ultrasound or CT confirmed appendicitis with a diameter less than 1.2 centimeters. So after our initial trial, we started to say, can we broaden these inclusion criteria, right? So we actually started to look at patients who had 1.2, 1.3, 1.4, and did historical chart review. And as soon as you jump above into 1.2 and higher, the rate of complicated appendicitis goes up to about 50%. Same thing when you take the white count above 18,000. Same thing when you have a fecal. So with those, knowing that the data is pretty clear that for early complicated appendicitis you should operate, we never expanded the criteria, because then we actually could be hurting patients. And then pain less than 48 hours. That too, if you go up to 72 hours, you increase the proportion of patients that have complicated appendicitis to about 50%. So these are sort of tried and true over time and confirmed in other studies. So patient choice study, 370 chose non-operative management, 698 chose surgery. That is also about 35%, about a third. And if you were to break that down by site, it's pretty consistent that when you offer this choice, about 1 in 3 families would prefer not to have surgery. And that, when you think about when we started our first study to when this study ended, that's over a course of 9 years of enrolling patients in a study. So it's pretty consistent over time. The primary outcome was the success rate. And in this study, it was a pragmatic trial. Nobody was sitting there saying you have to follow the criteria. Surgeons managed the patients, the team, the way they normally do. The success rate was about 67% at 1 year. The comparative outcome was disability days, which were significantly lower with non-operative management. And then we did a post-hoc analysis where we looked at the actual data in depth and said who met the criteria to go home but still had surgery. And there were at least 4 to 5% of the families that switched their choice, essentially. The kid was ready to go home, and before they went home, they basically said, no, we want the appendix out. So it counts as a failure in the study, but the actual success rate ended up being, if you did it based on clinical criteria and clinical improvement, was about 70%. And that, I bring that up because as we think about our newest study, that potentially will come into play. The one thing this study did, so people will poke holes at that study. It's a patient choice study. It's not a randomized trial. It's all fine. But it did point out the modern day morbidity of a laparoscopic appendectomy. These were 10 of the best children's hospitals in this country participating in this study. And these were the post-op complication rates in the surgery group, right? There was a 7.5% negative appendectomy rate. Almost 7% came back to the ED. 3% got readmitted. 1.1% had a postoperative infection, and 0.6, so more than 1 out of every 200 patients needed a second operation for something that could have been treated with antibiotics in the first place. Just putting it out there. You could have got a bias. People look at this data and they're like, no, there must be something wrong with the way you guys did it. So we'll get into Sean St. Peter's newest trial, but they also, across a multi-site international trial, including US and international sites, had a 7% negative appendectomy rate, and a larger study that had nothing to do with non-operative management and just looking at appendicitis outcomes showed at least 0.5% of postoperative small bowel obstructions. So other studies confirming this. So we concluded that it's a safe and effective alternative, and that among children with uncomplicated appendicitis, a treatment strategy with antibiotics alone was successful in most, and compared to surgery, it's led to significantly fewer disability days. So the other thing that tends to come up is, can people really make an informed choice, and do they want this choice? So we actually did a study of shared decision-making using appendicitis as the model disease. So this was another PCORI-funded trial, and we set out to ask, can pediatric patients and their caregivers effectively participate in informed shared decision-making in the acute care setting? And we used appendicitis as a demonstration case. This was a trial of a randomized trial of an iPad-based, we call it patient activation tool, so PAT for short, that was designed to engage patients and caregivers in the urgent care setting to work to be part of a shared decision-making process. This is just some snapshots of what it looked like, right? So the PAT started with some avatars. You could pick whether you wanted a person or a cartoon character, a male or a female. There were vignettes with physicians taking you through it. There are patient and family stories on both sides. We did things like use small videos. We accounted for literacy and numeracy. Now, what did the study show? So this was a randomized trial of this PAT versus a person who had a speech that basically included everything in the PAT, but it just was presented in a different format. And so we found similarly high scores on decisional self-efficacy and healthcare satisfaction. So the trial was a negative study because it didn't show that the PAT worked. But what it did show is whether you, no matter which one you got, you could absolutely, these families could participate in informed shared decision-making in the acute care setting with good decisional self-efficacy, minimal regret, high healthcare satisfaction. Within the PAT group itself, there was an interesting thing that we could do with it. So all of the patients, think about it, everyone got randomized to that arm. So this wasn't a trial about non-operative management versus surgery. Everybody got the choice. It's just a matter of how you got the information presented. So everybody who got the PAT, before they met a surgeon, got this iPad. And so they all got the same information in the same format. And then we have a values exercise, which I'm going to show you in a second, where we essentially presented the 8 most common reasons you might choose one treatment over another from our stakeholder group, which had 20 families and pediatricians and emergency medicine doctors and surgeons on it. So these were all kind of pulled together. And then they go through the values exercise. So we had a unique group of patients that's got this information presented in exactly the same way. So we could look at what were their choices based on, what were the things that were most important to them in what we thought was a relatively unbiased fashion. So this is what it looks like. They came up one at a time. So 5, you put them in any one of the 5 stars. After you'd seen them all, you would get a grid and you could move them around. Now that you've seen them all, right? Because sometimes you don't know what they are. You can move them around, and they were color coded to say, you know, this, if these are important to you, you more likely want surgery. If these are important to you, you more likely want antibiotics. And then they could actually print this out if they wanted to and talk to the team about it. So this is the list, right? And these are the treatment choices and how they were scored. And if you look at, for the surgery group, the top 3 things that were driving their decision was avoiding the risk of bleeding infection, not getting appendicitis again, and potentially avoiding the side effects from antibiotics. So that's what the surgery group, that's what were the highest things that were most important to them. Surprisingly, when you flip over to the non-operative group, the top 2 are exactly the same. Avoiding the risk of bleeding and not getting appendicitis again. And the third one, most important, was potentially not needing an appendectomy. So remember, this same information, no human involved to bias them, and they're choosing completely opposite treatments based on the same reasons. So what we concluded here is that the relative importance of the different risks and benefits are basically, it matters at the individual level, right? That each treatment it's interpreted and valued differently by the individual patient and their caregiver. And this really supports the need for shared decision-making when you're talking about treatments about uncomplicated appendicitis. So then where do we go from here, right? So do we need more studies, or are we ready to implement this? And if we are ready to implement it, what's next? How can we optimize or improve non-operative management? So like I said, most people want a randomized controlled trial. And that was the big knock. So there was a small one out of NYU. It was about 30 patients, showed almost the same results as our patient choice trial. And it confirmed the main reason why we did patient choice trials, which is that the number of patients who would be willing to enroll would be less than a minority. And I think they had about 20% of eligible patients that actually enrolled. In contrast, in our study, 85% of eligible patients enrolled because they were getting to make a choice. And the enrollment was really just for follow-up in answering the surveys. But Sean St. Peter did manage to pull one off, also again, with an enrollment rate of about 30%. So if you're a statistical person, that gets into the level of, do you have external validity with your results? But I would argue, since his results are consistent to our results, it probably does have external validity. But they did a multi-site international trial, 11 children's hospitals, US, Canada, Europe, 5 to 16 years of age, 936 patients. Their overall success rate was 66%, but they allowed patients with an appendicular thin. And so they confirmed, one, that the appendicular markedly drops the success rate. And then the bolded one, that's basically the patient population that's similar to who we're talking about continuing to offer an antibiotic choice of around 69%. So I think the effectiveness is pretty clear. Safety has been established, right? So no study to date has actually reported a higher rates of complicated appendicitis or surgical complications. And I'll pause here for a second. Some of you may have seen the most recent meta-analysis in JAMA Pediatrics. And if you haven't, they use the Clive-Dindo classification system. And what they basically, and it said their new finding was that non-operative management has significantly more complications than surgery. The problem with that is the definition of complication include needing an appendectomy. And when you look at this from a patient and caregiver standpoint, that's not a complication. That is part of the treatment algorithm. That is why they're choosing it, because they want to try to not have to have surgery if they don't. So if a complication is needing an appendectomy, by virtue of that definition, then everyone in the surgery group technically had a complication if you're applying it equally, which they did not. So that study didn't report anything. It confirmed everything else that I've told you so far, which is the success rate is about 70%, and that there's no higher rates of complications with non-operative management first. The other thing that comes up is cancer risk. So there have been some adult studies looking at non-operative management that suggests there's a higher risk of cancer. That's in particular patients over the age of 40 or patients who presented with complicated appendicitis. So to just dot our I's and cross our T's, we went back to our study and we looked at all the patients who had an appendectomy. So those who chose surgery and those who actually failed non-operative management. So it was about 824 patients, and there were no cancers in our study, which suggests that the maximum rate at using a 95% confidence would be at 0.4%. So cancer risk is low and should not really be a reason that we wouldn't offer non-operative management. The other thing that comes up is, what about long-term results? So these are incredibly hard in US-based studies because the kids, the parents move, they end up in different hospitals, they end up with different insurance, there's no universal payer system. So it's hard to get good long-term data. In our Midwest Pediatric Surgery Consortium study, we were aiming to try to get to 3-year follow-up, and by year 2, the follow-up rate was less than 50%. So we aborted. In our single institution study, we did manage to have decent follow-up, and the success rate was around 70%. It's basically hung right about the same. But again, it was not enough follow-up and high enough follow-up to basically be able to publish it. In general, when studies talk about recurrences over time, very few happen after the first 6 months. There are some adult data that suggests the long-term success rate is about 60% out to about 10 years. And there's one pediatric study that actually is very old now that followed patients in Japan for years, and they had about a 71% success rate at 4.5 years. So again, just to close the argument of do we need more studies or not, I would tell you we don't need more studies comparing surgery and non-operative management. The results are remarkably consistent across multiple now large multi-institutional studies in children and adults, both in this country and international. And so those are the 5 largest trials that have involved it. And if you look at the success rate, which is about the 4th column in, you can see that it basically bounces between 67 and 73%. So there is a substantial and definitive body of evidence that supports incorporating non-operative management as a standard treatment option for uncomplicated appendicitis. It's now supported by level 1 evidence in multiple trials. Again, this data is getting old. I don't know why we're trying to answer the same question. In 2020, the American College of Surgeons included it as a treatment alternative in their emergency surgery guidelines. And then more recently, in the 2025 guidelines, which were just published earlier this year of the World Society of Emergency Surgery, they have multiple recommendations, and they have a particular one for children recommending antibiotics as an alternative to appendectomy using shared decision-making. So this is what it looks like at the population level. So in the patients who choose non-operative management, about 2/3 are never going to need surgery, 70%, which means about 1/3 will have surgery, which means only 1/3 will be subjected to the potential complications of surgery. So your overall complication rate drops to about 2% versus around 8% if everyone has surgery up front. If you offer non-operative management, they need to know there's about a 30% chance of failure. It comes with a lower risk of overall complications for the population as a whole, less disability days, and lower costs. So we did a cost analysis study on our trial, and we did one in our first trial, and it's about 20% cheaper. All comers overall, so including all the failures and everything else, it's going to be about 20% cheaper. In our multi-institutional cost analysis, we did a true incremental cost effectiveness effect, and non-operative management remains cost effective unless the success rate drops below 30% in the first year. So since no study has ever reported anything kind of less than 67%, that's a highly unlikely probability. So it's going to remain cost effective. Obviously, if you choose surgery, you have no risk of recurrence. There are risks of complications, including needing another surgery. That's about 1 in 200. Disability days in most studies are somewhere around 4 to 5 days longer. And then it comes with the increased cost. So we are now moving on. I don't know about the rest of the pediatric surgical community, but we are trying to move on, right? And we really think that the evidence is really strong and consistent, and that we should be focusing on implementation by identifying the barriers and the facilitators to getting surgical groups to offer non-operative management of choice, and then starting to do studies that are going to maximize the potential benefits of non-operative management. And so the next question we're looking into is, do you actually need the inpatient observation? Can we do outpatient non-operative management with ED discharge? So why would we want to consider that? This is probably particularly relevant for the practice here, right? So first of all, there's the obvious pieces that go along. If I send you home from the ED, you don't have the hospital admissions, you get home earlier, you transition back to life earlier. So the kind of standard things you would expect by letting someone go home from the ED, similar to what happened with intussusception, right? It's become something that we try to manage from the ED without admission. It may actually lead to a higher overall success rate. So if you avoid the inpatient stay, you can get rid of some of that patient caregiver anxiety. So think about it. You just got admitted with your kid for appendicitis. You chose not to have surgery. You get admitted to the floor. This is still not mainstream. So the nurse comes in to check your vital signs and they say, oh, why'd you choose non-operative management? We almost always take the appendix out, right? So you start to question yourself. Surgeon might come in and say, you know, we usually take these out. Are you sure you don't want it out? You start to question yourself. So by actually getting them out of the hospital, you may end up with a higher success rate, just removing the patient caregiver anxiety. And then the next bullet, this is a veiled stab at the surgeons. So I'll just put it out in the open, right? If I come in and I suggest that, you know, I see anything wrong with you, I may prematurely declare you a failure and operate on you. And there are lots of reasons to do that. There's bias, there's your potential interpretation of the data, which objectively some people might say still doesn't say we should offer it. So how you value it, there's some bias, there's financial incentives to doing the appendectomy. There's a whole bunch of pieces that come into that. But if you're out of the hospital, if patients make their choice and we respect that choice and get them out of the hospital, there's less chance of influencing that choice subjectively. And this is where it can eventually become a game changer, right? So it may promote more equitable care and decrease resource utilization. So if you think about this, if we can show that if the data shows that you can do it with ED discharge as safely as you do it with inpatient observation, we could eventually get to the point where this is being diagnosed in the community hospital in combination with telehealth consultation with a tertiary hospital pediatric surgeon, pediatric surgical group, review of the imaging. Think about our medical record systems. We can do telehealth consults, we can view images, we can, if we have medical privilege, we can get into their EMR and see almost everything that they have. Diagnose it, you can start, if they want non-operative management, you can start antibiotics there. And if they improve, they can go home. And if they don't, then they can transfer to the main hospital. Take that one step further, regardless of whether they want surgery or non-operative management. If they meet the criteria, you can start antibiotics. If they go better, they can go home. If they want non-operative management, you do a telehealth to see how they're doing in a couple of days. And if they want surgery, you have your schedule, call them the next day, and you bring them in within a day or two, and you do a semi-elective outpatient appendectomy. We're not there, but if we get there, that's a game changer, right? And there was a recent paper that basically showed that the access to pediatric surgical care is getting less and less in communities and in rural communities. And for appendectomies, less than 50% of the hospitals that used to do appendectomies 30 years ago are doing them now. So this is actually a little bit of a public health crisis in terms of resource utilization. And if we can show it's safe and effective, potentially this is the next place we could go. There's actually literature out there to support doing this. So Dave Talon, who's an adult EM doc, his initial study of non-operative management was a randomized trial pilot study. They did 16 patients, and they actually sent 15 of them home from the ED. And they had a success rate of 87% at 1 year. And then the CODA trial, so the comparing outcomes for drugs versus appendectomy, the adult US-based randomized controlled trial comparing surgery and non-operative management. It's kind of the definitive trial people look at. They did some secondary analysis of that data, and they looked at what they considered outpatient non-operative management. So they looked at if you went home from the hospital less than 24 hours, and they showed those who went home for 24 hours versus after 24 hours had a similar success rate, maybe slightly better. And then they did a subgroup really taking it down to less than 12 hours. So those are probably most of the ones that went home from the ED, and the success rate was similar with similar adverse outcomes. So they concluded that outpatient antibiotic management is safe for selected adults with appendicitis. And there's actually pediatric data. So Steve Lee and his group, so when he was at UCLA, he had done some non-operative management work. And then with COVID, which really pushed a lot of non-operative management, they started to try to shorten the stay because they needed the beds and get people out of the hospital. And then they eventually said, well, what if we just let them go home from the ED? So they switched their protocol, and they did a comparison of sort of the pre and post protocols. And what they showed is that, you know, for that group, once they switched protocols, 19 out of the 28 that chose non-operative management actually were able to go home from the ED. Those who went home from the ED had a 7.3-hour stay versus those who got admitted to the hospital had a 23-hour stay. And the success rate was about 86%. There were 2 failures in each group, no serious events, serious adverse events, and the 30-day success rate prior to ED discharge had been 80%. So just going back to that general idea, if you get them out of the hospital, this is the confidence intervals overlap here, but the point estimate of what they were doing before they switched to letting ED discharge, the success rate was 80%. And then when they switched to this protocol, the overall success rate was 85%. So just getting a little bit of a touch that it may actually be better. And if you think about Talon's study, the 12-hour was also slightly higher in the group that went home. And so this study, I think, shows that it's feasible and the results are consistent with the inpatient piece. And you're not sending everybody home from the ED. You're just changing your protocol so that you give them their antibiotics. And if they basically improve rapidly while they're sitting there, you let them go home rather than admit them to the hospital, because assuming it works here like everywhere else I've been, once you get admitted to the hospital, the resistance to getting you out of the hospital, between all the steps that have to happen, you're adding 10 to 12 hours as soon as you decide to hit that admit button. So it really does make a difference, the location of where you do that initial observation. And as someone who's been offering non-operative management for almost 14 years now as part of a study or part of practice, there are patients that as soon as you treat them, they feel better very quickly. So there is a group that definitely, I would say, rapidly improves that this will work for. Then there's a group that it takes a little longer. And so having that bounce off to get them to continue with the inpatient pathway but we're potentially likely to be able to send somewhere between probably 40 to 60% of patients home from the ED, just based on anecdotal experience. And Steve's study, it would actually suggest that about 60% went home from the ED. So this is the application that Jason made, that's going in today. So this is, so we're trying to establish whether this is actually safe and effective on a large scale, right? So we partnered with PCARN, which is the Pediatric Emergency Care Applied Research Network. So it's a federally funded network of emergency departments and emergency medical systems to do trials in kids who come in through the emergency room, essentially. So it's a 22 site trial, 13 are in PCARN, 9 are not in PCARN. And it's a step wedge cluster randomized trial. So because this is a pathway, you can't really randomize at the patient level, right? You have to think about randomizing at the site level, because if we start allowing ED discharge, then, you know, Jason might say, well, we just sent the last kid home from the ED. Why can't we send this kid home from the ED, right? Because you can't do individual randomization. So it has to be at the hospital level. So basically at the start of the trial, everybody will be doing the inpatient algorithm, and then randomly picked, I guess, one hospital at a time will switch to the algorithm that allows the ED discharge. So it's the same exact algorithm, except the first 6 hours after the antibiotics start, you get to stay in the emergency department. And if you meet the discharge criteria, you can go home from the emergency department. Doesn't really change the risk profile. It just is changing the location of where you spend your first 6 hours. But that has a huge impact on what we could potentially do down the road. So this is going in today, and we'll see if it gets funded. We'll find out 8 months from now. So just to conclude, pediatric appendicitis, it continues to evolve. Hopefully, at least if you believe one message I got across today, it's not a surgical emergency, right? And that's probably the key to any of this, people accepting any of this down the road, surgeons, families, emergency medicine, everybody. It's not a surgical emergency. And it's remarkable, as I presented this to PCARN to get this approved, right? You have to go through a whole selection process. The emergency medicine doctors themselves were like, no, it's a surgical emergency. And I'm like, we've not been taking it out overnight for like 2 decades at this point. But they don't know what happens, right? When the patient goes to the floor, they don't know what happens. Another thing I think the world of pediatric surgery is there's really 2 forms of appendicitis, uncomplicated and complicated. And your treatment choices and timing of treatment should really be decided by that expected definition, right? Complicated appendicitis, if you have an abscess, if you don't have an abscess, you should have surgery. If you do have an abscess, it becomes a little bit more institutional or practice derived as to what's better. And so then it becomes a little surgeon driven. And then for uncomplicated appendicitis, there's 2 safe and effective treatment options with very different risks and benefits. So you can either have an upfront appendectomy, or you can have non-operative management with antibiotics alone. I'm not advocating for non-operative management to replace appendectomy, because the risks and benefits are so different. And the success rate was like 95%. That's a little bit different. But this is kind of in that gray zone where what matters to you will help decide what choice you want. And so it really should be used with a shared decision-making process, continuing to update what you include in your information as more and more trials come out. And with that, I will take any questions. Okay. Yep.
Are there any socioeconomic factors at the individual level, not population, at the individual level, that would, all medical conditions being equal, that would sway someone towards, or a physician to maybe consider the non-operative versus on-operative?
So that's a great question. So in our studies, we've looked at as many of those factors as you can get. So in the prospective studies, we can collect a lot of them. So we looked at socioeconomic status, particularly at income level, race, ethnicity, insurance status, caregiver education level, whether one parent worked or 2 parents worked, distance from the hospital. And the only factor that came up significant affecting the choice was whether they were transferred or not. And if you were transferred from another hospital, you were more likely to choose surgery. But otherwise, there was no difference based on any of those factors. And then that actually holds for the adult studies too. So some of that work from the CODA trial, some of their secondary analysis, they actually did a study where they looked at Spanish speaking versus English speaking. And when you look at the demographics in the population that was in there, the Spanish speaking group happened to be in their study 80% Medicaid, 80% low income, 80% less than high. So, and they showed no difference in outcomes. And then in our study, we actually did it. We collected the information, actually did it by each of those variables. As you think about, offering this to people, some people, well, they come from a long distance, we shouldn't offer it to them. Honestly, those are some of the people who would prefer it, right? Because they get to go home sooner. They don't need to, they can't go home overnight. I know everybody can stay with their kid, but they got to figure out what to do with their kids at home, right? So the sooner they can get home, the better. So I think subjectively trying to pick criteria that we would use to say we should offer it or not gets a little bit tricky. And I actually think if you offer ED discharge, you're going to remove some of the barriers for some people wanting to choose it. And then if we could actually get to the point where we can do it remotely, I think you remove tons of barriers to people choosing non-operative management.
A couple on Zoom here. One is from a community pediatrician. Do you change antibiotics given according to severity?
So most of our appendicitis protocols on the inpatient side, we have standardized antibiotics. I don't know, you're typically using either ceftriaxone and Flagyl, or you're using Unicin or Zosyn, depending on the hospital. For the study, most people, we've moved them to ceftriaxone and Flagyl because it's once a day dosing. And then outpatient, you transition. You're not penicillin allergic, you transition to augmented. If you are, then there's, I think, ceftonir and Flagyl or Cipro and Flagyl, depending on the whether it's a true allergy to penicillin or not. But based on severity, the antibiotics that we typically use are frontline antibiotics are the same.
Of your non-operative management group, what percentage were lost to follow-up at 1 year?
Lost to follow-up. So in the trials, most of for kids, most of them will come back to the same hospital. So it's based on EHR data. For disability, it was patient reported, so that we had to get in touch with the patient. I don't remember the exact number. The loss to follow-up is actually higher in the surgical group. And it's probably because it's one and done, right? Unless they have a complication that brings them back to the hospital, they don't think about their appendicitis anymore. I think the response rate was about 84 or 85% overall. But everybody had a chart review, and honestly, with the ability of sort of care everywhere for those of us who aren't Epic, and those other joint medical records, the general premise is if you had appendicitis and you got sent to Children's Hospital, they came back, you would have been sent to Children's Hospital.
Thanks a ton for presenting. It's a lot of great information.
Speak up a little bit.
Thanks a ton for presenting. It's a lot of great information. I'm Eric Hansen. I go back to the socioeconomic thing, and again, I'm struck by acknowledging also that to the north and the east, to me, is a black box, even though my son lives there. And it's high density. And I'm struck here by Arizona, where we have people who don't have electricity, who live 5 hours away, who live on Native American reservations. And like, that seems to weigh into a lot of decision making I make them as I talk to them about, can you get back to something? Anything. And it seems like, and so I'm wondering about the distance factor that you mentioned. The distance from, I don't know, Pittsburgh to Philly to pick a city, all close to each other. So you're gonna say it's far, but here it's like
300 miles between Pittsburgh and Philly. It's not that close. Yeah, I got you.
So you get black.
No, you're out here in the West. Your distances are an exponential level bigger.
So the distances and really what care is there? I guess I'm just.
So if I was advising a patient,
have the studies address that? That's my.
Well, the studies have used distance, right? We've looked at distance and we've looked at what they've chosen, and we've looked at outcomes too. So we're not only we look at the choices, we looked at the outcomes and whether there was any difference in them, right? The Midwest trial was done in the Midwest. So there are hospitals with catchment areas hitting 300 to 400 miles. Not quite. I mean, here you're probably getting into 750. Some of the places you're coming from, right? What I would say is I would advise a family, that's something to take into the treatment choice. But there are families who don't want their kids to have surgery,
100%.
right? So I don't think we should blanketly say, well, you live too far away, we're not going to offer it to you. I think you build that into your counseling. And it's a little bit of We have people who come to your emergency department all the time. They get brought in by ambulance, wherever they're coming, and they get sent home, right? So there's criteria people are using to send people home. And so you're going to apply those somewhat the same way. Right? If there's a patient that gets transferred in for a virus that you could send home, but you think they're too far away and you don't want, then you would admit them to the hospital, right? So that kind of gets a little bit, the emergency department one is one piece of the study. But if you're offering it with an inpatient stay, if they improve and they go home, the chance they're going to need to come back once they get out of the hospital starts to really drop. So if you meet the criteria, you make it out of the hospital, your chance of coming back is small. And that should be there, in my mind, they know how hard it is for them to get here. And there are lots of people who actually choose surgery for that reason, right? I had one family that I personally counseled that we were sitting there and they were weighing the risks and benefits, and they were all about they didn't want the kid to have surgery. And then dad literally went and looked at how much PTO he had left. And he said, this is my last PTO day. I cannot come back. We have to take the appendix out. So they chose surgery, right? So I do think it's individualized, but I think if you don't offer it in that open discussion setting, you are part of that discussion in patient care is the subjective nature of the surgeon, physician, whatever, right? The relationship with the patient. And they may ask you, what would you do? And fine, tell them what you would do. I think it's all about shared decision-making in patient-led care. And honestly, if I have one take-home message, if I have one impact on anything I've done in my career, I don't care if people are non-operative managed or not. What I want is people to offer what the options are and make a joint decision with the family, right? This whole body of work, one side product that has come out of it is it's now integrated into almost everything we do and almost every study that's out there now, right? So that's probably the most important thing that can come from any of this.
So Jamshidi on pediatric surgery here. Thank you for coming to share all of your work. And I think we're on pediatric surgery community, so aware of all that you've invested in this for a decade and a half. And I just want to say I really appreciate in particular you making the point that we're not reinventing the wheel here, because there's a bit of a sense of that when the adult trials were done in the 2010s, now to Europe and the US, like, oh my gosh, and you have people from lay public, even our anesthesiology colleagues coming, hey, did you hear that you can treat appendicitis without an operation? We've known this a long time. And so I really appreciate you making that comment and paying homage to that history of submariners in World War II, of the Peace Corps experience. I mean, there was data out of the Kaiser Foundation in the 60s that already said 30 to 35% risk of recurrent appendicitis, a rough 70% success. So I think those are valuable things to tell our patients when we're in that process of shared decision-making, that, hey, by the way, this isn't revolutionary. This isn't because he heard it on the news last week. This has been going on for the better part of a century.
Yeah. And I mean, and if you look, right, I tried to break it up into decades for you, right? I showed you the consistency in the data pre-2015, 2016. And then that last table, those are all the last 10 years, the large studies, right? Because one of the things as you build this momentum and you point out the history of where it is and you look at all the individual studies, you start to get more buy-in to then be able to pull off a large study. Yeah.
How did you get ED buy-in with that additional 4 or 5 hours in the ED for bent or clipped?
So we did the math, right? So depends on your hospital and your size. And that was the biggest concern that came out of the PCHGR group. But if you do 500 appendectomies a year in this, I know you do more, that's a system I don't know how you do in this hospital, but if you do 500 appendectomies a year, about 1 in 4 patients meets this criteria, right? So about 25%. And only about a third are actually going to want non-operative management. So you end up, it's less than a patient a week that you're keeping in your ED for less than 6 hours. So that's how I got buy-in. Because it's not going to overwhelm the ED with patients. Now, eventually, if we get to ED discharge and it's going to maybe overwhelm the outside EDs, but if they keep the patients there and they're not trenches. But that being said, as we designed this trial, so this trial, we call it the CASA trial, right? Children with appendicitis sent home with antibiotics. Dave Talon's acronym. He came up with CODA too, so he's good at making acronyms. But what we found, right? So it's been we've submitted it once and it got scored, but it didn't get funded. And one of the concerns was, you know, we're not including the rural emergency running community. They wanted us to like potentially do the study there first. And I'm like, I don't think you're gonna be able to sell that. So we went, but it's McCoy, right? So we went and we actually surveyed community emergency medicine physicians, community surgeons, and we have some of them as stakeholders on our team that will be part of all the meetings to kind of talk about all these issues. And when we've surveyed all of our investigators, the surgeons, the community docs, community and providers, all the patients and families, everybody's like, this is a great idea, but you got to do it. You got to do it where the pediatric expertise is first, right? So it's not going to have as much impact of saying, well, we're going to stop transfers right away, but we also don't want to put into perpetuity something that's potentially, if you don't do it on a bigger scale, you don't pick up the small signals.
And that was one of the things here too, is that early on, that this is a partnership between surgery and the ED. And so for us, Sharice Meacham in the ED has been a co-PI on the first round of the study and on the second round. And they heard this, they were part of it, and they actually very much in favor of this for the many reasons that Pete's gone through. And then also to the potential impact in the future of, you got a kid in Kingman, you know, can you keep the kid in Kingman with antibiotics and avoid them getting sent here? So I think they've been very helpful and a great partner in this so far.
Thank you.
Okay, one last question on Zoom, and then we probably need to end this, but and the non-operative management group, what percentage return to the ED or urgent care for abdominal pain complaints requiring re-imaging or labs in the first year due to fear, anxiety, et cetera? And was that included in the cost studies analysis?
It was definitely included in the cost study. All imaging done within, all visits and stuff were done within 1 year. I have to remember the number. So most of the kids who represented would get an imaging study, and then if they had appendicitis again, we operated on them. It was a very small number, and I don't know the number off my head, that actually showed up and didn't actually have appendicitis again. So that number is actually relatively small. You know, that being said, 7% of the kids with surgery came back to the emergency department, which is higher than most people think, right? So again, just back to one of the points I made, like when you actually measure, you objectively set criteria, right? Like these are the definitions and you look for it, you actually find it, right? Because when we were designing this study, the initial multi-study, the response we got as I was trying to get all the different surgical groups on board is, this is never a complication for appendicitis. Our negative appendectomy rate's like 2%. What are you talking about, right? My kids go back, literally, they go back to school the next day. It's not true. And then, so, I mean, and at that point I had to do my single site study and they just thought we were bad at nationwide, right? That was but they got on board and they said, okay, well, we'll put them in and we'll do this. And then the results were the same, right? So then we took it from 1 site to 10 sites. So we either have 10 really bad surgical groups or these are probably the real numbers. And then Sean did it in 11 sites, basically confirmed the same numbers.
Okay, thank you.